রফিক ভাইয়ের সাথে আমার পরিচয় আছে তো। আসসালামু আলাইকুম রফিক ভাই, আমি তো ওই যে আপনার সাথে ওই যে
দেখা হয়েছে
ওই যে এসিএলএস ওই যে কি বলে এটা এসিএলএস কোর্সের জন্য গেছিলাম, আপনার সাথে যোগাযোগ করছিলাম।
হ্যাঁ, ভালো আছো?
জি, ইসলাম হাফিজ ভাই ভালো আছেন? জি, আসসালামু আলাইকুম।
আসসালামু আলাইকুম, কি অবস্থা?
জি, ভালো আছেন না?
হ্যাঁ।
ওই শোনা, while we are waiting, আমাকে কয়দিন আগে
ওয়েট করতে রফিক ভাই, ওই যে ঈদের নামাজে হুজুর সবসময় বলে লাস্টে যারা বছরে একবার নামাজ পড়ে সুতরাং তাদের জন্য একটু ওয়েট করেন।
শোনা, ওইদিন একটা প্রশ্ন ছিল আমার অডিয়েন্সের কাজে লাগবে, যে এটা করছিল আজম, যে ডিজক্সিনের ব্যাপারটা, why it does not cause infrahepatic block. ডিজক্সিনের দুইটা কাজ করে, একটা হলো it is a vagotonic medication. So the AV block from digoxin happens because of its effect on the vagus nerve, and that effect is only existent in the up to the level of the AV node. এটা একটা। সেকেন্ড, ডিজক্সিন আরেকটি যেটা করে তার মেকানিজম হচ্ছে সাইক্লিক ATPase পাম্প যেটা আছে, ATPase পাম্পকে অ্যাক্টিভেট করে। তো ওইটার জন্য হয় কি, there is overloading of calcium inside the cell, and that is the mechanism how digoxin helps myocardial contractility. Problem হলো যখন ক্যালসিয়াম ওভারলোড হয়, then it creates another current on the side, similar mechanism to catecholaminergic polymorphic VT, and that becomes responsible for arrhythmia. তো এই জন্য ইনফ্রাহিস সিস্টেমে ডিজক্সিন করতে পারে এভি ব্লক বাই স্লোয়িং দ্য কন্ডাকশন, বাট ইট ইজ আনলাইকলি to do that. That was the reason of lack of infrahis block, but it can happen at a higher dose.
Thank you, sir.
না, এগুলো প্রশ্ন করলে তো তোমার ইন্টারেস্টিং কনসেপ্ট গুলো, মানে এখন অনেক স্টাডি করতেছে, মানে সেলুলার লেভেলে, বিকজ দে আর ট্রাইং টু ডেভেলপ ড্রাগস। এই যে এট এ মলিকুলার লেভেল, মাইটোকন্ড্রিয়াল লেভেলে এত স্টাডি হচ্ছে, এন্ড ডেভেলপমেন্ট অফ ড্রাগ টার্গেটেড টুয়ার্ডস দোজ রিসেপ্টরস।
আতার ভাই শুরু করে।
জি শুরু করে দেন। হ্যাঁ ফিরোজ।
জি স্যার, আমরা লাইভে যাচ্ছি স্যার।
Yes. Yep.
আবার করেন নিবা স্যার, কথা বলা শুরু করতে পারেন স্যার।
Good evening, ladies and gentlemen. Welcome you all to this webinar on ECG Basic and Beyond. This is the 27th lecture of this webinar session. In today's session, we'll discuss on case studies on ECG. We have got an elegant speaker with us, Dr. Aysha Cader. And we have got our course directors, Professor Abdul, Wadud Chowdhury sir, Professor Atahar Ali sir with us. We have got our international advisor, Dr. Rafique Ahmed, and other faculties like Professor Chowdhury Hafizullah Hassan, Professor MG Ajam, Professor and other Dr. Abdullah. Session will listen to Dr. Aysha Cader. Dr. Aysha Cader is working as Assistant Professor of Cardiology in Ibrahim Cardiac Center and Research Institute. May I request Professor Abdul Wadud Chowdhury sir to say a few words about today's session and Dr. Aysha.
Good evening, everybody. Today, we are going to have a session from one of the brightest students I have ever seen, Dr. Aysha Cader. At present, she is the Assistant Professor at Ibrahim Cardiac Hospital and Research Institute. She is not only brilliant, she is also very active. She is passionate about clinical trials and outcome research, and particularly focusing on acute coronary syndrome. And she is undertaking a part-time MSc in clinical trials at the University of Oxford. She also has an interest in global health and is a World Heart Federation emerging leader. Dr. Aysha served on the editorial board of European Heart Journal case reports and is a senior American Heart Association early career blogger. Most important, she is an academician. She not only learns herself, but also very eager to teach others, to share the expertise and knowledge with others. I'm really looking forward what she is going to present. Dr. Aysha, the floor is yours.
Thank you. Thank you so much, sir, for that very kind introduction. And thank you to the ECG study group for asking me to present cases today as well. And especially also to Professor Atahar Ali for persisting with this project and making sure it happens. It has been a long time since I dissected ECG at the NICVD with my mentors like Professor Atahar Ali. And right now I am mostly based in interventional cardiology with the cath lab. So I'd like to share some stories of myocardial ischemia and finding the culprit in relation to ECG. So no doubt ECG is the mainstay to be a cardiologist, and it's in fact the entry point. But practically when you dive deep into cardiology, roaming from the ER to the cath lab, everything really actually becomes a story. It means that whatever we see on an ECG in an ACS patient in the ER, and when we see the true picture of the inside on angiography, then correlations, mystery, confusion, and ultimately the true answer comes out like a sunny morning. So it's very important to be able to figure out the culprit. I'll be sharing a few cases, and there will very likely be polls, and I will be looking to the respected panel of experts for their expert opinion as well. So the first case is a COVID era STEMI. This patient came a couple of weeks, no, actually came the day before yesterday. He's a 47-year-old male who's diabetic and hypertensive and came with chest pain for 30 minutes. A quick bedside echo showed an EF of 50%, as we routinely do in our center, and this was his admission ECG in the ER. And this is his right-sided ECG. I'll quickly ask Rivu to post a poll as to which one is the culprit. Is it the LCX, OM, RCA, or something else?
Yes, ma'am, posting the poll.
Thank you. Sorry, so this is the poll. Circ, OM, RCA, or something else, and this is the ECG. So the majority of answers is RCA, which is very likely correct. We'll have to look at the angio. So we can see here that there's ST elevations in the inferior lead. So it's obviously an inferior STEMI and the lead 3 ST elevation is greater than lead 2. So that is an RCA occlusion, which we know is, this is usually the case with a sensitivity of 99% and almost 100% specificity. We also have tall R in V1 and an upright T in V1 to V2, which means there's a posterior extension. But in this patient, it probably extends further because there are very significant ST depressions extending up to V5 and also including the lateral leads of 1 AVL. And less well-known and less perhaps well-practiced, something that I admit I had to look up as well, is that if you look at the ST depression in V3, and the ratio between the ST depression in V3 and the ST elevation in lead 3. And if it is between 0.5 to 1.2, it indicates a distal occlusion. If it is less than that, it indicates a proximal occlusion. So very clearly, this patient hasn't had a very proximal occlusion. And we also have to look at the arrhythmias, particularly relevant to inferior STEMIs. And here there's a very clear AV dissociation with variable PR intervals, regular PP, regular RR. So he's very likely in complete heart block. So ordinarily we would activate the cath lab, but this is COVID times. And as per local protocol, we decided to thrombolize the patient with IV tenecteplase. This is the ECG 30 minutes afterwards. And you can see that the AV dissociation has now transformed into a Wenke-Beck, which is a progressive prolongation of the PR interval culminating in a dropped beat. The ST hasn't particularly resolved very much. To continue, we do serial ECGs, of course. So this is the ECG at 90 minutes, which shows what we call an accelerated idioventricular rhythm. That is a rhythm that is ventricular. That means the QRS would be greater than 120 milliseconds. And it'll be ventricular complexes with a rate of between 50 to 110. So this patient has a rate of about 120, I think. And this is actually important, particularly in the case of reperfusion, because this is a reperfusion arrhythmia. So you don't really need to do anything about it. It will resolve spontaneously, and it is a sign that there is reperfusion in this case. So this is the ECG done the next day. We can see that the ST has resolved. And because he's COVID negative, we took him to the cath lab. This was the angio that was done today. And this is the RCA. So the thrombolysis has worked in that there is no total occlusion. TIMI3 flow has been established. But of course, there is a significant lesion that's at the level of the RV branch, which is probably where the occlusion took place initially. The left main looks very ugly. There's a very significant distal left main. I initially thought I had dissected it there, but other pictures showed that it was actually a very tight distal left main lesion in a calcified overlying vessels. So at this point, I'd like to put a question actually to the panel of experts. So it means the acute STEMI was well revascularized. TIMI3 flow was established. What would you do next and when with this angiographic picture in this current setting?
Do you want poll, Aysha?
Sorry, sir. Maybe not a poll. This is a question mainly for the experts, I think.
Aysha, is the diabetic?
Yes, he's diabetic and a smoker. Diabetic, hypertensive, and a smoker, and he's 47.
Age?
The politician.
Age?
He's 47, sir. He's a 47-year-old diabetic, hypertensive, smoker, and politician.
Now, if the patient is diabetic and triple vessel disease, the guidelines suggest there is CVG is superior. But in this situation, what is your opinion?
So I agree completely with you. We took the patient off the table because there is no role of an acute revascularization. There is TIMI3 flow established. He has a distal left main very tight lesion as well as an LAD and an OM lesion as well. And we are also going to send the patient for CABG. So that story ends there.
Achha, can you go back to the first ECG?
Yes, sir.
Yeah. Yes. When we consider the posterior MI, which lead do you think are most important, V1 or V2?
V2.
V2, because it overlies the posterior wall of the LV actually. And that's the most important thing. And do you, this complete AV dissociation, does it suggest anything?
Sorry, sir, does it?
Suggest anything, AV dissociation? Does it signify anything?
That it's very more likely an RCA than LCX, obviously, and that it's above the PLV because we know that the PLV supplies the AV node. So if there's an AV dissociation, it could be that there's a PLV lesion as well. And actually, that's a very good point. There is a lesion in the PLV in addition to the RCA, actually, in this patient.
Yes. Rafique sir, কোনো comment করবেন, sir?
Right. Dr. Aysha, can you show the AICD
Sorry, sir.
accelerated?
Third
Yes.
ECG. Third ECG.
The ECG.
Yes, sir.
Yes, third ECG.
This one, sir.
Yeah.
Next
So
one. This one, yes.
Acha, Firoze, do you have question?
Do you
Or
think
I have
it
a
is
Firoze, I have a question. Is this independent system ever needs treatment?
Wadud bhai. But hello, Wadud bhai.
First of all, is it idioventricular rhythm or sinus rhythm?
Yeah, this is the question actually. Yes, whether it is the idioventricular rhythm or sinus tachycardia, Aysha.
That is also, yeah, there's a P, so it is a sinus tachycardia, I think. But the widening of the QRS, yeah, that's right. Yes, sir.
Can I
How
ask
would we
question,
explain
sir?
that?
Can I ask question, sir?
Yes, Govindo.
After getting tonic place, why ST elevation is more than previous ECG?
Baffles me. It should have revascularized, but maybe it's still evolving.
Yeah.
So one of the explanation that we see is that when you give the thrombolytics, you are actually lysing the clot and pushing the clot distally. So the overall microvascular load may be even more. But at that point, we actually need to look at the patient. The patient's chest pain is getting better, no other consequences, then you just sit tight. And you can also see that now there is a distinct Q wave appearing. So, and it is on evolution to recover from this. But my question to you is that, left main finding actually made the case easy. What about the right coronary alone? Would you have gone after that right coronary artery?
If he didn't have anything else, perhaps yes. If this was the only vessel, only remaining vessel, only culprit vessel, then perhaps yes.
But Aysha,
Yes, sir.
studies suggest if you have TB3 flow,
Yes.
and the lesion doesn't have any tight stenosis, is it fit?
I agree, sir, but isn't this kind of like a facilitated pharmacoinvasive strategy? Because we've thrombolized it, and the patient came last night, and today we did the angio. Would that fall in line with the facilitated PCI pharmacoinvasive strategy?
No,
Can I add something?
That is true.
Hafiz
But
bhai?
the pharmacoinvasive strategy that you take to the cath lab, and then going to the cath lab does not mean there is a commitment to do intervention.
Absolutely.
Dr. Narula has published that if you do that and then you don't see any residual, then you can just sit tight and don't do anything. Here, it is actually even worse because there is coronary ectasia here. So there is a positive remodeling, negative remodeling, the Klackov's remodeling, and therefore it is very difficult to oppose the stenting if you do it. Question is, what is the residual lesion here? If the residual lesion is not significant, then young patient, maybe we just sit tight and then see. That is one argument. If you want to be even more aggressive, you can evaluate this by doing an IVAS to see what is the, but question is, what you're going to see. You will see that there is positive remodeling and negative remodeling. So I think the left main finding has made this much easier decision.
I like to know, I'm not expert in invasive cardiology. I like to know, is there any fresh thrombus in the RCA, or is there any actitic lesion in the RCA?
Yeah, clearly in the angiogram, there is coronary ectasia. You see that there is a positive remodeling that the plaque and the arterial wall goes outward, and then negative remodeling that the lumen constricts. Here you are seeing these outpouchings in like a bean-shaped outpouchings, and these are typical of coronary ectasia. And these patients actually with the PCI doesn't do that very well. And Dr. Valentine Fuster argues that many of these patients, if there is, you need to think about giving anticoagulation in addition to the antiplatelets.
Thank you, sir.
Hafiz bhai, can I add one thing regarding Dr. Govinda's question?
Yeah.
Why stimulation still persists after 90 minutes given inactive place? Actually, there's the total occlusion in ST elevation MI. When you give the lytics, it tries to resolve the thrombus, but it takes time. You know, ST comes down at least 6 hours. So 6 hours to 24 hours, may this resolution process may happen. So immediately after inactive place, you may not get total ST resolution. If you get it, it is very well, you are lucky, but at least few hours you have to wait to get total resolution. So you have to wait, and if you go for pharmacoinvasive strategy, that is the other policy. But in that particular case, there is some residual thrombus in mid part of RCA. It is also evident. I think Hafiz bhai agree with me. There is some also residual thrombus is there.
Yeah, but the question is that ST segment, usually we see, you know, these German trials show me, you know, 2 hours post, they did this, you know, 60% or 70% ST resolution, and then look at clinically. Clinical
It is
very, very
successful
important.
thrombolytic criteria.
Yeah.
One important thing is that post thrombolysis you are supposed to do after finishing the thrombolysis, another 1 hour should pass and then do the ECG. That's better. Actually,
Yes.
too early because she had done it at 30 minutes.
Right.
We
Actually,
do,
100%.
yeah, we do it at 30 and then we do it again at 60 and 90. Yeah.
I think you better go into next case.
No. Aysha, can you back to your second ECG? That is the first case, second ECG.
The right-sided ECG.
No. Second ECG, the first case.
Second ECG.
Okay, sorry.
ECG number 2.
This is 2. This
Next
one.
Yeah. So Aysha, actually, the patient has got the RBB, na?
Yes, sir. Now it's the right bundle branch block. Yeah.
So
That's right. It's
right bundle branch block, complete heart block, but you did not put the TPM during the angiogram. What is the reason? Actually, how did you?
Because when we took him for angio, this was a immediate pre-angio ECG. Although there was an RBBB, the rhythm was sinus and the PR interval was normal. And he had a rate of around 70 to 80. So we didn't see the need to put a prophylactic TPM.
Aysha, let me help you out with here.
Yeah.
So we are obsessed in the cardiology that right coronary and sometimes the vascular supply is the key to give the complete heart block, right? That's what we think. But you can also argue, and we are seeing it in many patients, and particularly with the radial, my experience has changed because many of these could be vagal component with the inferior MI presentation. And with the vagal component, many of these are not infrahysian problem. And you take this vagal component out, I actually give preemptive atropine with the radial because I don't want to make a mess in the groin with the temporary wire, and I wanted to know whether I can get away. So I actually preemptively give, because I know that this may cause trouble down the line when I inflate the balloon and stent. So with that, it just goes away. And if after the subsequent time in the hospital, the patient is coming back to sinus, right bundle and no other issues, then you may be able to get away. I don't know whether you gave any atropine or not, but
No.
it does help a lot.
It was just an
And also
angio.
pain control. Important pain control is also important. And the vomiting control.
So I've got a question. I have got a question for Atahar sir, Wadud sir, and Rafique sir also. For the students, if a patient comes with complete heart block with inferior MI, will you send the patient for thrombolytic first, or will you go for TPM and then followed by thrombolytic? In exam, what would be the answer?
Atropine first, see the response and consider the rate. If it's too low, I'm going to put a TPM and then go for thrombolysis as well. Together, we can do everything together, isn't it? It depends upon your expertise. If you are a radialist, it's not a problem actually.
But you have to put the TPM in the femoral root.
Yeah.
After giving thrombolytic, there is a chance of increased bleeding, hematoma, all
Why
this.
to see the response of atropine first? As Hafiz Bhai was mentioning, you see the vagal component first.
So practically what we
doesn't work, you will go for TPM and then for thrombolytic.
Yeah.
Exactly.
do in the night, so practically if it comes at an inexperienced hand like ours, we would generally, if it doesn't respond to atropine, I would put a sheath and keep it there. I won't do a TPM. I'd keep the sheath and then thrombolyze the patient. If the necessity arises, then afterwards.
In that case, you have to keep the cath lab open throughout the night.
Oh yeah, we have that. Yeah, so that's like if we can ask them to come in. Yes.
We have the temporary.
Be careful that the atropine and wait and watch usually does not work if the patient with complete heart block to start with has hemodynamic compromise. Then don't go that route.
Can I ask about the role of isoprenaline here?
Isoprenaline for the rate?
Yes, sir.
Is it available now? I don't get it.
Yes.
No,
We
no, no,
have
no.
it in our center.
No. This is available.
Okay,
so let me,
available, sir. Very
This is
Aysha, if I have
available.
time, I will show you the case.
We routinely use isoprenaline in EP studies.
Isoprenaline is a common drug used in the EP lab very frequently. The drug is not uncommon, but question is whether it is recommended or not. Yes, it is practiced. Actually, it is practiced outside the Dhaka. Some of the patients are sent with the isoprenaline drip, but where in the center where the TPM is available, if there is indication, this should not be the practice. That is the isoprenaline.
Something, please.
Yeah, Khalid Bhasan.
Yes, actually, in a bradycardia of ischemic origin, I think isoprenaline should be better avoided. Actually, it is a degenerative. Yeah,
setting, yeah.
Yeah, it is arrhythmia-prone drug. It may cause some.
And it leads to VT and VF.
So it is better to avoid isoprenaline in ischemic setting at least.
From Faridpur, actually, from Faridpur, we get a lot of patients. They already getting isoprene, then they refer to NICVD, especially Faridpur region. But sir, in Firoze Bhai, actually in the exam setting, if patient complete heart block, theoretically you should go for TPM, then go for lytis, because there is a puncture-related complication. It may happen in even experienced hand. That is the other issue that you should tackle by your own expertise and in own way. But in exam, they have to answer actually first go for TPM, then go for thrombolytics.
And in we should be aware of the lead tip-related complications of the TPM in a thrombolyzed patient. We should be careful about that.
We have had
emergency, double emergency.
I have seen some cases.
Dr. Aysha, you can go for the second case.
Aysha, second case.
Yes, sir. The second case was like about a 55 to 60-year-old male. He was, can you hear me?
Yes.
Yeah, okay. Sorry about that. There was a connection issue. So he was a cardiologist, diabetic, family history of CAD, came at 2 in the morning with a chest pain of around 1 hour. And this was his ECG. Which one would be the culprit? Is it the circumflex? Is it an OM or is it the RCA? Rivu, could we have the poll up, please?
Yes, ma'am, sharing the poll.
Thank you.
Ripu poll, please.
So option A is circumflex, B is OM, and C is RCA. I think we can do 20 seconds next time for the poll in the interest of time.
Okay, ma'am. I'll give 20 seconds from the next question.
Yeah, thanks so much.
Here is the results.
Okay, so there's equal distribution of circ and RCA, but not of OM. That's interesting. So this ECG, although there are cues, the patient had ongoing chest pain. And we can see that ST elevation in lead 2 is just a little bit more than lead 3, which is more consistent with the circumflex being the target or the culprit vessel. And there's also involvement of the lateral leads, clear ST elevations in the lateral leads. So this is an inferolateral STEMI. And it was 2 in the morning, and the patient was a cardiologist, so naturally, and he had ongoing chest pain. So we activated the cath lab. And this is his left system. It's a very interesting angiogram and a very interesting scenario for 2 in the morning in hindsight. And this is his RCA. So we see 2 lesions that could be the culprit. This in the RCA, and we see this other tight lesion in the OM. My question to the panel is, could there be anything else in here that we're missing? So we decided to chase after the circumflex because the ECG very clearly indicated that it's most likely a circumflex. And once it was wired, we found that a very, very, very large OM was also visible. So 2 wires were put in and a very large OM was visible. So clearly the OM is the culprit here. And Hafiza was just saying that we are obsessed with bifurcation. So with a very large OM and that kind of side branch, the patient was given a bifurcation stenting for this culprit vessel with a very satisfactory angiographic picture. So it was neither the circ nor the RCA, it was a very large OM branch extending down. Case 3, shall I move on to the next case? Or?
Can I see again ECG of...
left dominant or right dominant?
I would say this is
ECG, please.
So it is a ECG.
Yeah, sorry.
ECG, please.
In respect of the coronary angiogram, there should be a PLV branch. It was not visible in the right side.
No.
So definitely we have to suspect that there is something coming from the left circumflex.
Yes, that's exactly, yes, sir.
Is there any posterior extension here in ECG?
No, sir. I would not say so because I don't see a stick. I mean, although it's taller, but I wouldn't think so.
I think I should next one. Next case.
So, okay. In the interest of time, I have 4 more cases. So yeah, the next case, this was a 62-year-old diabetic hypertensive male. And in this case, this was a patient who had
the challenge is by the EKG to find the culprit.
Yes, sir.
That's step 1. But I'm not too obsessed about every time, because another step is that after going to the cath lab, it is even more important to find the culprit.
Absolutely.
So, and then you had the circ had a little dye seeking. And then sometimes it is difficult to guess that it would be codominant or not. But right coronary had no features for culprit. So it's most likely you go for the culprit and then you explore this. And the bifurcation here is a little different because this is it was not there before. This is an ad hoc bifurcation lesion.
Yes.
So that is even more challenging. Yeah.
Yes, sir. This case was done by Saidar sir at 2 in the morning. So credit to him for chasing the culprit. Yes, sir. The third case was a 62-year-old, again, clearly what is clearly an inferior STEMI, but in this case, there was a further complication. The patient came with chest pain of 1.5 hours, but he had a history of cabbage in 2004. That was about 16 years ago. And it's important to know then which grafts he had. So he had a Lima to LAD and a venous graft to the RCA. So in this setting, what might be the culprit? Could we have the poll? Is it the RCA? Is it the circumflex? Is it the OM, or is it something else?
What do you mean by this something else?
I'm leaving it open. Could it be the graft?
Yeah, that's the point. That has to be for the youngsters. You
Yes,
have
sir.
that in a post-CABS patient, you have to consider that possibility as well.
Rivu, could we have the poll, please?
Yes, ma'am. Starting the poll.
RCA, circumflex, OM, or the graft, as Wadud said.
Ma'am, will I go for 20 seconds this time?
Yes, 20 seconds, please.
Okay. Okay.
That's interesting. Majority is RCA, but there's a few who think it's a circ and some who also think it's a graft. So very well done. This ECG is, of course, an inferior STEMI, and of course, it indicates, we've discussed it before, that it's very likely the culprit looks like an RCA culprit, but it's important to remember that this patient had a prior CABG. So this was a pre-COVID case, and naturally we activated the cath lab. Gentleman came around 11 in the morning. And this is his left system, which of course shows both the LAD and the circumflex were occluded from their mid parts. He had a Lima to LAD, which was patent, which we looked at later. And it's interesting because before we could engage the RCA, the graft actually got engaged. And we can see now what the culprit is, because this is the SVG to the RCA with a heavily thrombus-laden graft. And the RCA was, of course, a CTO that was there from before, which is why he had a graft to the RCA. This was done a long time ago, before CTOs were opened as frequently as they are today. So in this setting, what would you do next? Would you do a primary PCI to the native RCA? There are lots of schools of thought regarding revascularizing the graft. Would you do a primary PCI to the SVG to RCA? Would you thrombolize the patient, or would you do something else? Here, I don't know what something else might be. It's an open question.
And will I start the poll?
Yes, please.
Okay.
Could it be that thrombus the something else?
Yes, sir, it could be thrombosuction. I agree. It's like Wadud sir has ESP, prediction of the next move.
Actually, the grafts, these venous grafts, they're often clogged with gelatin-like substances. That's why it is recommended for doing a graft PCI.
Yes, sir, I agree. But in primary PCI, what would be the, there is no real,
Used earlier, it was recommended.
Primary PCI means that there is an acute event in a vessel and you are doing it. For the right coronary, native right coronary, I think that will be really challenging, and it is actually contraindicated.
Yes.
And then for the vein graft, is the culprit, but the question is how you prepare the vessel. That's very important. But you can talk about a lot of things. But I would not give thrombolytics in the vein graft. First of all, vein graft STEMI is not that common. Vein graft acute coronary syndrome is mainly non-STEMI. If you do get a vein graft STEMI, then big trouble. And the lytics often doesn't work that well. And the grafts may be challenging, and you get aspiration and all that. But I don't know what did you do?
Agreed,
First
sir.
wire it, and then
Great
find out.
thoughts. Yes, this was a case done by Professor Maximul Haq, where I assisted, and we did something else. Yeah.
And all that. Yeah, lucky.
Yes.
You are
Yes.
damn lucky that this is a focal lesion.
But we had to aspirate. So we did something else first. And
well,
then
you can do aspiration, or you can do is, because what is going to happen once you give the stent, you'll be pushing the debris. So you can give a cocktail in the vessel, adenosine or verapamil or whatever you have to prepare the microvasculature, because you'll be pushing a lot of debris downstream.
I agree, sir. So on that thought, I actually have a question, because we know adenosine will cause bradycardia, and this is an inferior STEMI with a graft to the RCA, which will probably end up in bradycardia at some point when we even aspirate. In that case, do we still give adenosine?
If the patient has no complete heart block to start with, or high-grade AV block, you give adenosine until prepare the patient that we may ask you to cough. Why that works, I have no idea. But we had a patient like last week, patient went into only cardiac standstill. You see the P wave, cough, 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 came back. So that's you prepare. Adenosine is very short, 3 to 5 seconds half-life, so it's usually good, no problem.
Thank you. So interestingly, we aspirated, we stented, and then we saw that we needed to post-dilate. In hindsight, maybe not the best idea, because at this point, we then had slow flow. And this is the importance of continuing to look at the ECG in a STEMI, because on the monitor, we could see that the patient was going into a severe bradycardia. And at this point, we had to give atropine and also IC GP2B3 inhibitors, because we figured we did not use an EPD. We don't have EPD on our shelf. It's very likely that some of the thrombus and some of the debris shifted distally, leading into this bradycardia and slow flow. So we gave him IC, intracoronary GP2B3 inhibitors, as well as atropine, following which he recovered, and a satisfactory angiographic result. So some people I've shown this to have asked me why we didn't give adenosine, because the treatment for slow flow or no reflow is adenosine. With bradycardia, we probably shouldn't give it in that case, I guess, right? I mean, we didn't.
Don't worry about that. You'll be okay.
Okay. Yes, sir.
And then if you have this, you can have, nicardipine intracoronary. If you have nicardipine.
We don't.
We don't. That's the problem.
Yeah. Shall I move to the next case, sir?
Yes,
you can. By the way, some will go from the, you are in a groin. Some will say, okay, what the heck? I will put a temporary wire and give adenosine.
We had nothing on the groin at this point, because we went left radial.
Okay.
Yes.
Even better.
Yeah, because of the Lima, we went left radial. Yes, sir. So the next case was a 67-year-old diabetic hypertensive, again, a graft case. I'm deliberately showing grafts in the interest of, because people have seen regular STEMIs. So these are interesting ones that I encountered, which I figured might be interesting for an audience as well. So this patient had PCI to all 3 vessels, LAD, circ, and RCA in 2014. And all of them occluded after a year, following which he had cabbage and 3 grafts. Here he had Lima to LAD, sequential SVG to OM, and diagonal, and came with chest pain of 1.5 hours and this ECG. This is also a COVID time case. He came a couple of weeks back. This is the right-sided ECG. Could we have the poll, please? What could be the culprit here?
Yes, ma'am.
Bearing in mind that we know he has 2 grafts, because when we get a graft STEMI, we always look at what grafts have been done, because now we know they can be the culprit. So could it be the native RCA, the native circ, the native OM, or the graft, which is the SVG to OM diagonal, actually, sorry, SVG to OM diagonal, not the RCA. So the poll, the majority assume it's the native RCA. We know it's very likely an RCA lesion, but there's also very significant ST depressions in this patient, extending to 1 AVL as well. And he had occasional PVCs, initially in a trigemini pattern, followed by an occasional PVC pattern. And this is his right-sided ECG, showing no ST elevation in V4, so there was no V4R. And given that it's COVID, of course, we thrombolize because we don't activate cath lab without a negative COVID test. But the next day we did an angio for this patient. And I mentioned before that his natives were all occluded, which is why he had the cabbage the following year. So these were his native vessels, nothing to do there. The stent in the mid RCA was patent, which is why he didn't have an SVG to RCA. His two graphs were actually the Lima to LAD and the SVG to the OMD1. So this is the RCA with a stent that is patent and a bit of an aneurysm and possibly perhaps a lesion there, which is very likely what the culprit was in this inferior STEMI. And this is the graft vessel. So the SVG to OM diagonal is patent with good post-graft flow. And the Lima to LAD is also patent with what looks like a lesion distally, but perhaps not significant. So in this inferior STEMI with no graft to RCA and a patent TIMI3 RCA, what would you do next? Would you do anything, or would you just do nothing further in terms of percutaneous revascularization? Can we have a poll? Bearing in mind, I'm not really sure if the Lima to LAD is actually a significant lesion. And
Okay, so Lima to LAD is significant or not, that's not going to explain your, so then let's not be a scientist, let's forget that.
Yes.
The main thing is the inferior, right? How to explain the inferior.
Yes.
And then if you have a op report, then good. If not op report, if I cannot figure out two things I really wanted you to do, one is look at the ventriculogram if you have, or any wall motion abnormality, echo or any imaging, and then aortogram, make sure that you're not missing a graft. Sometimes there is a graft, and then it just go, but that is less likely because your native right coronary artery is patent. In the presence of significant right coronary artery, you're obligated to find that. Now this is a ectatic vessel also, and I don't know that it doesn't explain the ST segment elevation that we are seeing, and there is a good TIMI3 flow.
This is post-trauma.
Was that?
Perhaps this is after tenecteplase because we didn't go for a direct angio. It's very possible that,
So question is, do you need to do anything?
I would not say so. We didn't do anything for this patient.
LIA, leave it alone.
Yes, that's what we did. So nothing was done to revascularize this RCA because clearly there's TIMI3 flow and perhaps he had a lesion that was open.
But before making that decision, a couple of things I will do. Make sure the patient is symptomatically okay, hemodynamically okay, and then the EKG is getting better.
Yes, sir.
If all the moons and stars are aligned in the same direction, then you are good.
Yes, it was, and he's doing well. So we didn't do anything about that. It was just thrombolysis.
Aysha, can I have a question?
Yes, sir.
So actually, we know the criteria for localizing the lesion in the native coronaries. Is there any criteria for localizing the lesion in the graft vessel?
Sir, I was hoping that would be answered by the panel, but I didn't find anything that would localize. I think we just have to localize it to the territory that is supplied by the native and then correlate that with the graft that it is attached to. I think that's the only criteria that, and there is no way to know whether it's a native or the graft, I think, until you do an angio, as far as I know.
Firoze?
I agree. But the important thing, Atahar, since you asked, it's a technical question. I usually look at the EKG and try to localize by the EKG because to minimize the catheter exchange and find and think about when I go for the culprit, I usually go with the guide. That helps me to prevent the catheter exchanges. And second, we have a time issue that you may be in a crunch time. So by doing the guide catheter, you actually minimize the time. So that way it is very helpful.
True, thank you. Next case, Aysha.
Thank you, sir. So the next case was a 75-year-old female. This case was done about a year and a half ago. She was diabetic, hypertensive, dyslipidemic, came with a STEMI, chest pain for 3 hours. And even hers, like Hafisa was also saying, the importance of knowing which grafts and getting the op note, that is very crucial when we have a cabbage case, particularly in STEMI, because we know minute is muscle. Here, she had an SVG to LAD, an SVG to OM2, which was skipped to D1. So it was 2 to 3 grafts essentially, and 3 grafts rather. And she also had an SVG to LAD, which was occluded before, which we knew from a previous angio, which was done after the bypass. And this is the ECG showing an anterior STEMI. What could be the culprit? Could we have the poll, please? Is it the native LAD? Is it the native diagonal? Is it the graft, the SVG to LAD, which is redundant actually, because I've already told you it's occluded? Or is it the SVG to OM skip to D1? Which is the culprit here? Or plain and simple, is it a native or a graft? So.
Was the patient revascularized after detecting that SVG to LAD was occluded?
It was totally occluded, like non-visualized even by pigtails.
So how the anterior wall was getting supply? No, nothing was done to native LAD.
SVG to OM was skipped to diagonal. So I don't know for what reason, but initially they had put a graft to the LAD as well as an OM skip to diagonal. So because that was there, it was D1, nothing was done at that time because he was.
Aysha, I thought this is EKG conference. We'll have some input about the EKG itself.
Yeah. Yes, please. Yes, sir.
What is the rhythm?
This sinus rhythm, but here there's an aberrant. It's not a premature ventricular contraction. It's more like an intercalated PVC because there is no compensatory pause and it is not premature.
The ST elevation in the precordial leads.
Yes.
And the rate is rather slow.
Yes, it's bradycardia. Yes, it's
yeah. So it's a bigger trouble on the way, maybe.
This is also a very interesting case.
Yeah.
That was challenging to revascularize, from what I remember. So yeah, we've discussed that it's an anterior STEMI with bradycardia, and this patient has had CABG, and we activated cath lab for primary PCI. So this is a non-dominant RCA, which with a significant lesion, but we won't be worrying about that because this is not an inferior STEMI right here. The circ is occluded from its mid part.
Even if it is inferior, so non-dominant right, hear me out. Non-dominant, we never go after non-dominant. Even it looks like big, unless there is a significant arrhythmia with this. So it's only by the case reports. Non-dominant right, even if it looks like you can put a 2.25 stent, please don't go after that. That's actually not a good idea.
Yes, sir. And we have the culprit, which is the SVG to OMD1 skip. So I don't know what the right answer to this is. We did a pigtail, the SVG to LAD was occluded. It was occluded from before. And we have this one graph that is supplying the diagonal, which is the only supply to the LAD.
And the native LAD is closed?
Yes, native LAD is this. There's a flow up to, yes, mid part. Okay. After the diagonal, it's occluded. So that diagonal is literally the only supply to the post-graft LAD, which is why that's what we went after.
Functional LAD now. This diagonal is now going almost to the apex. It is now acting, it is grown and it is now functionally the LAD. So this is very important. That explains this. So yeah.
STEMI, yes, sir. So that's what was revascularized. The SVG to OMD1, the skip graft, which eventually ended up in the diagonal, was what we revascularized here with the satisfactory angiographic result. And the patient was symptomatically much better because she was very symptomatic throughout the procedure as well. And the last case, this is not a STEMI, but there's a culprit. And it just goes to show that we can't always figure out what the culprit is, and maybe there isn't an answer to everything. This was a 68-year-old diabetic male who came last week. I saw the patient in the ER with this ECG. This is also post-CABG with 3 grafts, SVG to OM, SVG to LAD, and Lima to LAD. And he had a leaked troponin. This was the first
So,
CCG.
in
and-
our emergency room, they may call it STEMI because you
Yes, sir.
see 3 and AVF, there is ST elevation.
Yes, sir.
But there can be another explanation for that.
Maybe, maybe not. But 20 minutes later, this was his ECG. We sent him up to the CCU and this was the ECG with no progression with the, I also looked at that first in the ER and I was
So
looking
why
to this.
you would
but-
not be calling it STEMI?
Because I mean, I don't see any elevations in AVF or lead 3. So there's no contiguous lead ST elevation.
You go back, you had 2, 3 and AVF.
In this one, yeah.
3 and AVF you had. Yeah.
If you have ST elevation.
Elevation am I?
And the
So,
next one, sir, when there isn't,
It's
what
like
would you
once
call
Rajakar, always Rajakar.
what would you call this CCG? That probably threw me off.
In this ECG, there is also ST elevation in lead 3 AVF. And
AVF is this, I mean, would you call it an elevation, sir?
No.
no, sorry, lead 2 and 3.
2 is
So
actually
let me tell
depression.
you another thing.
Sorry.
When you have a patient clinically behaving like an MI and there is ST elevation, you don't, is it 0.75 or 1 millimeter? You don't be too critical because if one thing is florid, the other thing you don't need to look at. But if the story is iffy, the ECG is iffy, then you can say iffy plus iffy is more iffy. But if it is overwhelmingly STEMI presentation clinically, then you act like a STEMI. And here you have a significant changes in the precordial lead. Big trouble, you know.
Okay, how about the ST elevation in AVR and bleeding?
AVR, right.
AVR, there is ST elevation.
Yeah.
So it might be left main involvement.
Yeah, Aisha,
Yes, sir.
AVR ST elevation and gross ST depression in global
Yes.
ST depression.
Multivessel.
Left main
Otherwise,
involvement.
it is left main or triple vessel disease.
Yeah, but remember this patient has cabbage. So
Right.
I'm not jumping on that yet because in otherwise non-cabbage patient, that is a very important. I call it, you should be able to smell the left main. And even more importantly, alert the cath lab that I have a sick left main coming. Why? Because left main patient, unless the cath lab is alert, suddenly one injection patient may go into VF arrest. So this is important that the team works in sync. You need to share your thoughts to the team so you are prepared. But anyway.
I completely agree. So this was actually very confusing and that's why I left it for the last and I don't think it warrants a poll because this was COVID times. It was last week that this patient came and I mean, we didn't thrombolyze him on this because it was a cabbage patient, like you said. So difficult to figure out what the culprit might be. And we don't want to just push down lytics in an elderly patient without knowing for sure if it was in fact a STEMI. And we couldn't activate the cath lab because unless we have negative cases, we don't activate cath for these patients in COVID times. But we did give him low molecular weight heparin and did an angiogram the next day after we found he was negative. And this is the picture. So we have a non-dominant RCA.
You did the echo, right? The echo was helpful.
Yes, the echo actually showed a lateral wall hypokinesia. Only it wasn't severely hypokinetic, which was comforting because we were keeping him in the CCU without really intervening. But we do a bedside echo that was consistent with a lateral wall hypokinesia. And in fact, within a couple of hours, he improved and he was not symptomatically very severe. He had chest pains, he had dynamic ECG changes, which we did because we do serial changes once we saw that. But he was symptomatically actually not too bad. Neither was the echo, but we put him on Clexane. Initially, we had to give morphine, of course, and then did an angiogram the next day, which showed a non-dominant RCA. The LAD was, of course, occluded from its ostium from before. This is pre-cabbage LAD. The circ is severely calcified. And interestingly, there was an SVG to OM. So we can see that there's some retrograde competitive flow across there. So it's probably occluded at the top. And So this is the SVG to OM. There's a lesion at its anastomotic site. The SVG to LAD is fine with post-graft flow. I'm not really sure why they had a Lima to LAD as well as an SVG, but anyway, they're both patent. So his LAD is fine. It's the circ that's worrying, and that is consistent with the lateral wall hypokinesia as well as the gross ST depressions in the lateral leads as well. So what would you do next here?
Let's start the poll.
I think this is for the panel mostly. So
Okay.
yeah, it's
Okay.
big.
Hafiz sir.
I was waiting to see because I don't want to do the case. so it depends. You can go to their native, but native will be relatively tough because you have this proximal circ and the delivery of devices will be difficult to go after that. So if you go to the graft, then you can give a little balloon and then see whether you can get the nitro, and then probably might be easier, relatively speaking. Yeah.
Yes. So this was a case done by Professor Atahar Ali, and he actually went for an IVUS guided stenting of the circ. I'm only showing 4 shots, but there were about 25. He pre-dilated with an NC in the mid part, again pre-dilated osteoproximally, did an IVUS, sized the stent, stented it, post-dilated, and this is the result. And yes, and this is the post-revascularization ECG. So
can you play the picture again?
Yes, sir.
Last one.
Yeah.
Okay.
And this is the post-revascularization, which is very satisfying to look at, given the gross ST depressions initially. So, I mean, the story ends or does it? All these small steps, the history, the ECG, the imaging, angiograms, they're all different chapters of the ischemia story. And it's important to anticipate the potential culprit vessel. We have learned because, as Hafiza mentioned, minute is muscle, you can take in the correct guide going in, especially in the setting of ACS and especially in STEMI. But this is not always straightforward, as we have seen, especially when it's a case of prior revascularization, and sometimes you need to think out of the box in terms of the culprit. And we are actually going to be seeing more and more of such complex cases in the future because people are living longer, they're having perhaps more PCIs, even more CABGs. And these post-CABG ECGs are sometimes mysterious. You need to anticipate which one may be the culprit. And very important to know what has been grafted before and to know the vasculature that you're dealing with. And last but not least, not all stories have an ending. Sometimes they may remain a mystery. I would like to acknowledge all the primary operators of our cath lab whose cases I have shared here and all my mentors. And with that, I would say thank you very much for the opportunity. And I hope you learned something from these. Thank you.
Thank you, Aysha, for beautiful cases.
Thank you, sir.
Thank you, Dr. Aysha. Thank you, Doctor. You have shown nice cases, including ECG, angiogram, and also PCI. We can move on to the next session. Professor Hafiz sir, have you got something to show us?
Okay. I am trying to get this. Okay, can you hear me now?
Yes, we can hear you, sir.
Okay, so let me go to the share. So I'm going to show some EKG tracing actually to see. I can show this ECG. Okay, so I have this. Can you see? Oh,
No,
Can you
no,
see my screen now?
not
No,
yet.
Not.
Yes,
coming.
it's, yes.
See now?
You
Yes.
can see now.
Okay, okay. All right. So case 2, can you see it?
Yes,
Yes.
we can see.
Okay, so let me go quick because we are already running out of time. 38-year-old, this is this week's cases. 38-year-old schizoaffective disorder from a local jail, septic shock on pressors. This was the initial EKG. Then patient went into atrial fibrillation, EF like low, normal, and then this patient then had this. After the atrial fibrillation, the ICU team they started MEO and then called us after finding this.
What is the rhythm in the upper strip? Oh, pole. Yes, good.
Sir, should we go for 30 seconds?
Yes, 30 seconds.
Okay, okay.
So it was interesting because they called us and luckily I was not on call that night. So. Okay, so this thing came up, right? The isoproterenol and then scopolamine patch. Okay, so 33% said continue to watch and do nothing. No, okay. C, majority is saying continue to observe. That's very reassuring, actually. Atahar bhai, you have any comment?
Actually, I want to know what is the rhythm in the upper strip? Is it a AFib?
No, the upper is nothing. There is no key. This is asystole.
Is
Like
probably
a pause, long pause. 11-second pause. And the upper panel is a noise, but this is the pause. And then came back after 11 seconds. So the patient, the baseline EKG, nothing, no conduction system, MEO induced and on vent with the vagal MEO, all these pause. I think it is probably reasonable to start nothing and then observe. They usually don't need anything, regardless of the length of the pause. And he came back to sinus rhythm and subsequently so far has been okay, is almost ready to be discharged. Isoproterenol in the acute ischemic setting, we already discussed. In the chronic setting, sometimes the scopolamine, I don't know, the EP experts can say that scopolamine patch sometimes may work. I don't have a good experience of scopolamine patch, but in the chronic setting, maybe. In the subacute setting, where you have a lot of other issues and not acute ischemia or infarct going on, isoproterenol has been tried in the past, but we have difficulty to get this from the pharmacy. Any comments? But it's very reassuring that 2/3 of you picked up right that we don't need to do much. So the next one is 92-year-old AFib and COPD, and then had evaluation for left femoral fracture and optimized. We said okay to go for operation, but this was the EKG. Question is that the anesthesia says this is atrial flutter, and whether you agree with that or not. And my question to Rafique bhai, Atahar bhai, that what is the 1, 2, 3, 4, fourth beat from the left in the lower panel? What is that? And then maybe the last but one. What is this rhythm?
You want discussion or there is poll?
Now poll, let's see poll first and then you can comment.
Okay.
Ooh. Some are saying junctional. 33% saying junctional. Atharva, you agree with that?
No, no.
So we said that it is probably sinus with PSCs. That's the best fit.
Yes.
And then multifocal atrial rhythm or wandering atrial pacemaker because of the morphology changes, but it really looks like 2, not quite 3. So we had a big debate. Our EP attending says this is sinus rhythm PSCs. Our majority actually voted for wandering atrial pacemaker, but I actually think that this is sinus rhythm PSCs, but definitely not atrial flutter, which has definitely implications. So, but there is also left axis deviation. Don't forget that. And then patient was optimized for going to surgery. There is no need to do anything else at this point for this patient. I think we talked about so much. I'm afraid that Rafique Bhai probably went left. But anyway, this was the other one, that 59-year-old heart failure, reduced EF, and COVID. And then patient also is now track peg. And this is the EKG. This is a very important one. Low EF, track peg, but patient is full code, so everything needs to be done per family. So I can point out that we see some inferior axis lead 2, 3 AVF PVCs. Is that helping us or hurting us to diagnose? So
Atrial flutter with LV.
Was that Atharva?
Yeah, yes. Actually, your options are the VT, atrial flutter with LBB, WPW, atrial flutter with LBB and PVC. Actually, Hafiz bhai, I think VT is out.
Yes.
As because actually the QRS, although the QRS complex is white, if we put the Brugada criteria or other criteria, there is, I think, except the rate and the widening of the QRS complex, there are no points in favor of the VT.
And in the storm of VT, it is very difficult to get another PVC, right?
True, exactly true. This is a very useful point. That is, there is no points in favor of the VT. And
yes.
Atrial flutter with LBB, yes, this is a good possibility. Is atrial flutter with LBB, as because the rate is 150 nearly.
Yes.
I think rate is nearly 150 regular, and yes, these are the
rate is regular, and then the QRS is left bundle morphology.
Right.
The PVC has an inferior axis. That means it is looking like left bundle. So RV OT type PVC.
Right, exactly. And WPW is again out.
Yes.
Because it is fairly regular. In case of the WPW, it should be irregular in rate as well as irregular in duration and amplitude, all those. So the WPW is out. Atrial flutter, LBB and PB, yes. So B and D are the 2 points you should consider.
And actually our participants did very well. 75% got it easy, no problem. And then, okay. I don't know, I can show you the last one. So this is an interesting because I got this from my ex-fellow, and he sent me this and said, interesting, huh? And no other comment. Then I see this in the early morning, and then I texted him, what's the story? No answer. So I submitted to our EP conference. So what do you think? This is clearly a telemonitoring, and they picked up this. So I give you what information I had. He's saying interesting tracing. What is the interesting tracing about? A, B, C, D.
Is there any difference between the tracing on the left and the right side?
There is little. Yeah.
Can you please go to show mode?
Photo show. Okay, good.
How is it? Slide show mode?
Yeah, it is in the slideshow now. Can you see it?
Still now my net is slow. Not came yet.
Channel 1, 2, 3.
How was the patient at that time?
I tell you, this patient is my fellow, ex-fellow, he's an attending now. He's in Iowa. He sent me this saying that interesting, huh? And then I called him, I said, what is the story? And he did not answer. So I give it to our EP guys. And good thing is that I'm not involved in the patient care. Patient is in Iowa. So he was actually sleeping. An hour later, he gave me information. I'll tell you that.
Seems polymorphic VT.
Artifact. See.
No.
Rafique is back?
Hello. Now, Rafique sir will comment finally. Is there Rafique sir? I say, you want the poll?
Yeah. I actually wanted to do the poll after the second one. But anyway, let's see. It is interesting that what people think about this one.
So we'll discuss after the poll, na?
Yes, but the tracing is ugly, isn't it?
Yeah, definitely.
Okay, so A, wow, 80%. And then C, I don't know, remember. C is artifact, 23% artifact. So our EP guy told me that this is artifact. Okay.
But I think
No, wait, Rathar bhai, before you discuss, I know. So then I got the info. The info is, so what do you do next? So the info is,
Hafiz, can you go back, please?
Yeah. Rafique bhai is back.
Okay. So the question, if it is an artifact, look at down the right side, the middle strip. There are 1, 2, 3, 4, 5 wide beat. And after the 5th beat, there is a pause. It can't be artifact. The first beat of those 5 is a fusion beat. And then final, this is wide. So this is not artifact, clearly. It is real. It is not polymorphic, because if you look at the top strip on that, if you're in the middle strip, it's all looking down. It's just amplitude is different. You cannot compare. Of course, in the top one looks that it's shifting. So that may fit in with the polymorphic morphology. The top strip, the middle strip is not. So I don't think it's artifact.
So after the EP guy looked at this tracing for Dr. Guru Raj, actually, he's very, very sharp. So After quick saying that in nanosecond artifact, I said, don't you want to know the story of the patient? And then he looks at more and more, and then he gives a differential. But this is the story. 70-year-old, 1-year-old from Iowa, history of palpitation, and went to see the cardiology fellow who is an attending now. He has some dizziness, no other past medical history. He did an echo and ordered a tele, and then patient left for vacation in South Dakota. Now he's got this from the tele company, and what he should do now? Ask the patient for setting up an appointment for a stress test, went back, see a cardiologist, and then he saw the other answers. So let's see what how you take it. So on the treadmill, if we see the PVCs coming more and more near the end of the stress test on the treadmill, that's one thing. Sometimes we see PVCs kind of disappear as the exercise test goes. So let me see this. What is C? Patient go to the local ER, right? So after Rafique bhai pointed out polymorphic VT, we need to understand that gravity of the situation. So he went to the local ER, got a cath. It was a Prox LED 95% fixed. Any comment, Rafique bhai? And this is important that how nicely you pointed out how to differentiate artifact from the VT. And also the polymorphic VT, the nature of it, the ischemia is very important to rule out. And because that can be a killer.
So my professor in Japan told me something.
Yeah.
That before you tell a patient's symptom is due to anxiety, you need 20-year experience. And after 20 years, you don't call anybody suffering from anxiety neurosis. So if you want to call something artifact, you must spend time before you call it artifact. If you want to do a quick diagnosis, you go for the most dangerous diagnosis. That means if I just quickly glance at it and I don't have time, I should call it VT. Yeah. If I want to call it artifact, I have to go step by step and really prove that this is artifact, because this patient would have died anywhere. And I have seen patients like this, proximal LA dilation, presenting with VT and putting on a treadmill, PVC, went to non-sustained VT. And patient had it's the funny part, this patient has a negative nuclear stress test, but I sent for a cath and had proximal LAD disease.
So that's what is very important. Don't rush. Even experienced people sometimes in the moment of excitement rush. So it's better not to rush and then take a calm, quiet decision, Anyway, Rafique bhai, you have something?
Is that time? Or you're going to stop today?
No, sir. Half an hour.
Okay. So let me see if I can get this going. We want to come back to simple life now. We had enough of excitement and difficult stuff. So I'm going to go very simple. And so this is, because this is ECG session, I want you to be able to read ECGs. I mean, the bottom line is that I want somebody in Nauga, a Guy Banda, to be able to read ECGs. And this is one of them. Please give a little time before you put it up, because I think they can't see the screen.
Review 20 সেকেন্ড দেখার পরে 10 সেকেন্ডের জন্য দিও।
ওকে স্যার।
10 সেকেন্ডে একটু বেশি দিও।
স্যার আমি স্টার্ট করেছি, আমি একটু এক্সট্রা বাড়িয়ে দিচ্ছি, সমস্যা নেই। ওকে।
Is the poll on now?
It's on, sir.
Okay. That's excellent. Basically, the reason I put the old inferior MI, there is a Q wave in lead 3. And Wadud and others will agree that this is probably within acceptable limit. Just one lead doesn't make an inferior MI. And then I put the rate 90 to see if we can, so everybody answered basically rate 66, PR, interval, QRS duration. And so everybody is paying attention to this. Thank you. Please give a little time and then please give the poll.
Okay, sir. I'll start after 10 seconds.
Okay, so that's a good distribution. And majority said sinus rhythm. That's interesting. If you look at the P wave, there is P wave before each QRS, but the P wave is inverted in lead 2, 3 AVF. So that can't be sinus. And also, if you look at the P wave in V1, it's positive, V4, V5, V6 is negative. So even though the vote was sinus rhythm, it is not sinus rhythm. So this is an ectopic atrial rhythm. Now, in the ectopic atrial rhythm, I put two diagnoses. One is old right bundle branch block with old inferior MI, and the right bundle left anterior block. I mean, I always get confused. Is it MI or inferior? If you look at lead 3, there is a small R wave. I'm going to put my pointer. So there is a small R wave here, and even in lead 3. And for left anterior block, left axis deviation plus small Q in lead V1 and smaller R in V3, that's left anterior block. So it's not an inferior MI. So the diagnosis is ectopic atrial rhythm with right bundle left. Now, junctional rhythm, it's a possibility because when we get junctional beat, there can be retrograde conduction. The way to differentiate is what is the PR interval. If the PR interval is 160 milliseconds, it is unlikely that junction is conducting retrogradely. Thank you. So we'll do the next one.
Sir, can I point out?
Yeah.
The thing is, for rhythm, it starts from junction, goes both downwards and upwards. Then the P wave should come within the QRS or after the QRS, not before.
That's true, but sometimes I'll show you another one. So I'm coming to another one. I have a series of ECGs. The other thing is that, as you mentioned, if it is a retrograde P wave, it is coming in the center of the heart, and the V1, normally you see a narrow peaked P wave if it is a retrograde. But this is a very wide P wave, so it is unlike a retrograde P wave. So next one.
Sir, I have a question, sir.
Yeah.
Sir, this is before. Sir, for the student in the examination room, sir,
Yes.
there is sir, I think that the PR is short in the V5, V6. Even it also looks short in case of the V2.
Yes.
Is there any scope to put the differential diagnosis pre-excitation, sir, in this ECG?
Okay, so the question is, the PR is short. When we measure the intervals, I have to take the longest interval. And longest interval is actually in, if you look at lead 2 and 3. And that's basically close to 160 milliseconds. What's happening in V3, V4, it's because of the, one possibility is that the P wave is showing only the terminal portion or distance from the AV node. Pre-excitation is a possibility, but we don't have a delta wave in this one. So there is absence of delta wave. If you look at the QRS beginning, it's very sharp. So yes, that's a consideration. But let's look at this one.
এত স্যার মহা ইয়া আছে দেখি
কি এটা সুন্দর, this is a nice ECG, it has many things in it.
এবং তার patient patient sir,
a patient 65-year-old, I don't remember the history of this patient. So the heart rate is 84. The question is the choices, so the answers have spread all over the place. Sinus rhythm, ectopic atrial rhythm, junctional rhythm with 2 sinus beat, junctional rhythm with, let me see what is the maximum numbers in ectopic atrial rhythm. Okay. Unfortunately, out of
I like number 3, sir. 2 sinus beats as well.
Yes, there is 2 sinus beat.
Yes, sir.
If you look at here, there are 2 sinus beat. So what's happening? There is QRS complex. And if you look at lead 2-3 AVF, there is a P wave which is very close. It's close to almost 60 milliseconds. And that brings up to Wadud's point that if there is a retrograde conduction, it should be inside the QRS or after the QRS. But a lot of times, if we have antegrade slowing, you can see the P wave just before the QRS, but it should be within 80 milliseconds, usually not beyond 80 milliseconds. So I thought this was a junctional beat with retrograde conduction. And then there are 2 beats here, which are probably sinus beats. Why sinus beat? If you look at lead V1, they look biphasic. So the 2 sinus beat. And then I'm going to, unless any faculty has any other comment, I'm going to go to the next ECG.
Sir, could it be what?
Could it be what? Can you repeat it, please?
Wandering pacemaker.
Yeah. So wandering pacemaker will be
wandering atrial pacemaker.
Yeah, if it was wandering atrial pacemaker, we will see different morphology P wave with variable rate. What is happening that here the junction is competing with the sinus. And that's why we are seeing. If you look at the first P wave, it's a little different from the second. Probably this P wave is probably that a degree of fusion or something like that. So I think it is purely junctional. I mean, you have a valid point.
Because of wandering pacemaker, the RR interval will not be this regular.
Exactly. So it will be irregular RR interval because the P to P interval will change. Anybody else, any comment? Okay. So this is the same patient. You can see when the other thing that I added acute MI to this just to make sure that people don't ignore that part. I mean, the same patient, if you see the next day, has whopping ST depression and there is a Q wave in septal Q wave with T inversion. So this is the ECG, another one. I'm just showing it that there is no P wave before each QRS complex, but there is a retrograde P wave, as Wadud mentioned. Normally it will be within 80 milliseconds, but sometimes it can be a little far away. The way we know it is retrograde is because the relationship between QRS and the P is consistent. So it's the junctional beat with a retrograde P wave. And the same patient, when the patient is in sinus rhythm, you can see the P with first degree AV block.
So Rafique Ahmed, on that EKG.
Yes.
So this patient also has right bundle, right?
Incomplete, yes.
Incomplete right bundle.
Yes.
And no other conduction system. So
No.
this junctional rhythm, the etiology is what?
Well, if you look at this patient had bradycardia. I don't remember, this is from 2000, I don't remember the clinical scenario. Sometimes patients develop vagal episode and can develop junctional beat and the sinus goes down and just junction takes over.
Right.
So I wish I had the clinical scenario to tell you, but you see the same day, 4th of November in the morning, and then later on, it's basically normal rhythm. So this is another
Looks like
one.
more of our problem than patient's problem.
Yes, it's just diagnostic issue. Basically. So if you look at here, the first beat, the P is on the QRS. But the second one, there is a reasonable PR, and this is, I thought, is conducted. And then next one is junctional beat with a retrograde P wave, and then retrograde P wave. So they're just showing that it is just transitioning from sinus bradycardia, and they are competing with each other. This has no clinical significance. It's just that we need to understand that this can happen with competing beat. So I have two more, and then we're going to stop. This is these are repetitions, but I'm doing it so that we keep repeating simple ECGs and we know what it is.
So Rafique bhai, while they are doing it, you said that this is not an issue and usually no problem, but it is an issue because we get concerns like this.
Yes.
And then they are on our nerves, and then a young ICU attending will be saying, I need a temporary wire now, like it becomes a problem.
That's true. That is very true.
স্যার এই জিনিসটা এখানেও অবজার্ভ করি যে এই ধরনের একটু ইসিজি দেখলে পেশেন্ট একেবারেই স্টেবল,
Yes.
পেসমেকার অ্যাডভাইস করা হচ্ছে বা হচ্ছে। আজকে আমি দেখেছি সাইনাস ব্রেডিকার্ডিয়া, তার অ্যাবসলিউটলি কোনো কার্ডিয়াক ইস্যু নাই বলে, কিন্তু তার হার্ট রেট 50-এর কাছে থেকে লোকজন বলছে তোমার তো পেসমেকার লাগতে পারে ইত্যাদি।
Okay. So majority diagnosis was number 2, sinus rhythm with 2-to-1 AP block with first degree AP block, sinus rhythm with Wenkeba, and then Wenkeba with first degree AP block. So I'm going to discuss it. If you look at this, clearly that is when my pointer is there is 2-to-1 AP block. However, the PR interval before the block is long and after the block is short, and that fits in clearly with Wenkeba. And then if you follow, after the block, PR gets progressively longer, and then blocks again. So this is typical Wenkeba, and the reason I added baseline first degree, this should be in the report because the baseline PR after the conduction is not normal, it's prolonged. So the diagnosis is sinus rhythm with Wenkeba AP block with baseline first degree AP block. And the second diagnosis that I will take sinus rhythm with Wenkeba AP block. I mean, it is true 2-to-1 AP block, but I think we need to get into a little bit more detail in the discussion. And then,
Sir, can I ask you?
Yeah. Go ahead.
If this RPPP pattern, along with this picture,
yes,
what is the chance of the patient developing complete heart block in future?
Okay. The question was this ECG and right bundle branch block pattern. Unless the patient has symptom, I am not going to treat it any different because you see, we have a lot of patients with first degree AV block, right bundle branch block, even left anterior fascicular block without symptom, and we do not. Yes, there is a higher chance of developing, but this block is mainly at the AV node level because it's Wenkeba. But I mean, it is good to follow those patients. I have patients with marked prolonged PR interval.
All AH issues, is it?
What is it? It is. I think so. Yes, it is AH issue. for the audience, when we say AH means it is the conduction from atrium to the his bundle, which is the basically conduction through the AV node. So this is another patient that you see this is 2-to-1 heart block. But if you look at the PR is long. And then, we always try to say, is it Mobis 1 or Mobis 2 second degree AV block? It is difficult to say from this ECG what it is. We just say it is 2-to-1 heart block. But one of the clue is Mobis type 2 usually have normal PR interval. And the same patient, I have another ECG. If you look at it on the top 2-to-1, in the bottom, PR is first degree and then long and then blocks. And then first. So this was Wenkeba AV block with. So one of the clue of differentiating Mobis 2 will be Mobis 2 normally will have a shorter PR interval. Brings us to this ECG. And so let's
I say a person is known by the company he keeps. If the 2-1 has first degree AV block, that means this is okay.
Yeah, that's good. All right, so let's look at this one.
This is a good one. Is the patient having chest pain, Rafique bhai? No.
Sorry, I can't take any more chest pain. And we had enough.
Nausea, vomiting, diaphoresis. But honestly, the cardiology ECG session should be interesting and entertaining. People should be relaxed, and enjoy.
Oh, this is good. Excellent. I mean, I think even the 4-person answer, nobody said, the reason I put this, the first choice and the second choice, actually this ECG, a lot of times have been missed by physicians, including cardiologists, because the P wave is just at the end of the T wave, and it looks like an E wave, and people call them as sinus bradycardia. But anyway, in the setting of bundle bunch block, if we see any bradycardia, we should always look for a second P wave. And so this is Mobis type 2, and look at the PR interval. 2-to-1 PR interval is normal after the block. So that's what it is. And let's see if I have anything else. Otherwise, I'm going to give me one.
I have a comment.
Yeah.
I really request the participants to answer these questions because no one is going to check who answered right or wrong, but it helps us, the faculty, to know where our participants are. And also it is fun to assess yourself, because then it makes all worthwhile. Please participate. It's very important that you participate. And also it is good to make decisions in cardiology. We are not dermatologists. We are cardiologists. We need to make decisions right away. And right or wrong, many times we make mistakes by taking quick decisions. But that's what we learn. We also made mistakes. We still make mistakes. That's okay, mistakes. But this is a good avenue that you can answer and then check that you are with the majority group who also can be wrong. So
yep, good. Thank you. I think that's it. We are done here. So as Hafiz mentioned, that please answer this. Whenever there is a poll, please try to answer. If you do it right, it reinforces your knowledge. If I answer something wrong, I am committing myself. Committing yourself is a great idea. Thank you very much.
Thank you, sir. Thank you very much. We are almost at the end of our session. I must thank Dr. Aysha Cader, Assistant Professor, Ibrahim Cardiac Center, for participating in our session and showing some interesting ECGs with angiogram and all other things. And I must also thank Professor Hafiz sir, Rafique sir for showing interesting ECGs. I think we can conclude the session.
Just 1 second. Khalek and Motion is here. Congratulations to both of them for PhD confirmed professor position.
Who are recently promoted as Professor of Cardiology, Professor Mohsin Hussain and Professor Khaliqujaman. Khaliqujaman and Mohsin bhai, are you with us?
Yes.
Yes.
Firoze also mentioned
Khalek. You are going to give the treat.
International Medical College. Universal Medical College, sorry.
Khaled Mohsin bhai.
So the reward from Atahar bhai will be, and from Wadud will be, they will be asking you guys to present next time.
But Khaled Mohsin, you need to turn it. So Khaled, I think everybody knows he comes from a background. I mean, he comes from a very tough background. I was lucky enough that his father was my professor of medicine, and he would teach us regularly. I mean, it's an incredible amount of clinical teaching those days. He will take class every day. It's one of the things he used to do. Every day he will come to our class and ask our name. And he would say, "What is your name?" He would say, "Rafique." "Well, Dr. Rafique, can you say this?" And then he will keep asking every day. And at the end of the month, he knew everybody's name. I mean, it is a remarkable teacher. I mean, I remember him very fondly. And Khaled, I'm glad that you are in full-time academics, and I don't think you will be a terror like your father, but will be a good teacher for the student.
Thank you, sir.
Khaled bhai kintu join korche Professor of Cardiology in International Medical College.
Yes,
I know that.
Don't say terror, because after one of the medical student had a vasovagal syncope in my round, I am now super nice.
No, but remember, the teachers that we were afraid of, they made us what we are today.
Yeah, but it doesn't
No
work that
question
way
about
now.
it. No
Now
question
you'll
about
get now you'll get a call from the dean.
Oh yes, that's true. That's very true. Thank you.
Thank you, sir. Thank you very much. Atahar sir, you can conclude the session.
Yes, thank you very much, Firoze. And really, I'm also happy to congratulate Professor Mohsin Hussain and Khaliquz Zaman, our colleagues, and big claps to these two guys, that is Professor Khaliquz Zaman and Mohsin Hussain, and also Professor Sabina Hashem. She is not here, but she is also with us always, all the time. So these three people are the professor. Sir, I will request Professor Wadud, Rafique sir, Hafiz bhai, and Firoze to stay for a few minutes more after the conclusion of the session.
Thank you.
And first of all, I like to congratulate Dr. Aysha Cader. Actually, she has opened a new area of the ECG. Actually, I did not have any concept about the GRAD vessel acute coronary syndromes, sir. Really, I did not find any ECG previously, but this is the today I have got some interest about the GRAD vessel when there is problem acute coronary syndrome, particularly affected the GRAD vessel. Congratulations, Aysha Cader, for opening the new session. She is always extraordinary. And finally, I like to congratulate all our participants, particularly, yes, Aysha Cader, thank you very much for opening the new area of the ECG, that is the GRAD vessel acute coronary syndrome. Really, thank you very much.
Thank you so much, sir. Thank you for the opportunity.
Thank you, sir. Thank you, Atahar sir.
So you asked review to, that is view to others and conclude the session, and just
now it's time for closing the session for everyone.
Sir, I will start
See you
the process.
next week.
Give
Thank
me
you
a few
very much.
minutes then. Okay, sir.
Okay.
Firoze?
Yes, sir. Review.
Everybody muted, এবারে আমাদের এই কয়েকজন বাদে।
Not yet, sir.
আমার মনে হয় বাকিগুলা অফ করে দিলে হয়।